Okay, I'd like to call the 911 State Advisory Board meeting to order. Start with roll call. Sheriff Edward Bonner.
Chris Herron here for Sheriff Bonner.
Chief Reginald Chappelle.
Present.
Lisa Hoffman.
Present.
Sheriff Mark Pazin. Not here. Leslie Wilson.
Present.
Chip Yarborough.
Hanan Harb for Chip Yarborough.
Chief Peter Bryan. And I got a email from him last night. He should be here a few minutes late, so he should be coming shortly. Chris Henshaw.
He should be here any second, too.
Okay, Chris should be coming soon. Chief Robert Nicolini.
Amy Crutcher for Robert Nicolini.
And Chief Sam Chappelle. I'm sorry, Spiegel. I just promoted you.
We're not married, okay?
We'll do this again.
That's a first time.
Chief Sam Spiegel. I almost did it again. Okay, our agenda today is a little bit different than we've had in the past. We're going to start with a presentation, and then we will go and approve our minutes and get back to our normal meeting. So I'd like start with the presentation with a medical perspective on Next Gen 911 with Dr. Jim Dunford. Thank you and welcome.
Good morning, everybody. Hi. I'm not sure if I advanced the slides myself. Okay. All right, good. So thank you for having me back. I know I wasn't very clear when I spoke a couple weeks ago, so I'm back to try to clarify my remarks and make sure everybody knows what I'm talking about. Anyway, I'm here to kind of give you guys a little bit of a perspective from the City of San Diego medical direction point of view. I oversee the 911 system for fire communications in San Diego. I'm also the president of the Heart Association in San Diego, so I see that perspective. And even yesterday I was at a breakfast with the Assistant Secretary of Health, Federal, and Chief Technology Officer for the government, all looking here in San Diego at West Wireless, where there was a breakfast where there are these remarkable things that are going on with sensing devices that people anticipate will really revolutionize healthcare. And of course, these guys all think this stuff's going to go to 911. So as it's all being developed, I just want to inform you and kind of give you a little bit of a kind of a clinical point of view of how we run San Diego's Fire Communication Center. So briefly, I'm going to use three arguments here, and you've got handouts if you can want to follow either way. But one is sudden cardiac arrest, one's heart attacks, myocardial infarctions, and the third is stroke, and how Next Gen 911 might improve this process. I was also in New York City last week and spent time with a guy named John Freese, who's a good friend of mine, who's the New York City medical director. Got a chance to see what New York is doing, and you know, everybody's doing it slightly differently, but nevertheless, across the nation, you're sort of seeing wireless transmission of data, you know, into centers, and then basically getting pushed, and then the whole thing gets intermixed, and so it's this integrated systems that we're really trying to go for. So this goes without saying, I'm talking to you guys, but you know, at least my vision of 911 is to provide a single point of care for contact to help for aid in emergencies of all stripes, to assign resources that are proportionate to the need. We're trying not to send everything to everybody. We're trying to assist also lay rescuers until help arrives by providing instructions. So from a clinical point of view, you know, whatever you guys like, I don't care. I can talk in the dark. I do it all the time. My wife always tells me that I should shut up. Okay, and then the other secondary goals that I see is to preserve resources for the people that are most in need, and to prevent unnecessary lights and sirens responses. We don't want to send all the time. Some systems do that, but we want to be more informed than that. And just one reason why we should be careful about that is the fatality rate of EMS personnel is over twice the national average for other employees. So, you know, right here on Midway and Rosecrans a few years ago, we had a fatal collision, and we all experienced these, you know, see them in the news. So we don't want to dispatch stuff unless we really have the most accurate information to deploy. So if you haven't been to San Diego Fire Communications, we're up near Montgomery Field. We're an accredited center. As you guys probably know, there's a national accreditation organization called the National Association of Emergency Medical Dispatch. It's an academy that encompasses police, fire, and medical dispatch now. It's out of Salt Lake City. Other systems use something different. Seattle has a slightly different approach, but basically thousands of communities from London to, use the MPDS system. There's a photograph of our comm center. We actually are a center that actually dispatches for 4 different agencies. I'm sure you guys have the same kind of thing. You've got PSAPs that are feeding to secondary service answering points. That's our model here. And when we go other, like highway patrol, obviously those calls coming from, through the CHP, God knows really what the hang-up time is right now in that. And I want to emphasize that. You're probably all very familiar with that issue. Medical Priority uses, we run on a TriTech CAD, which is a local company here in town. We use MPDS's algorithms. It's all scripted stuff. We have high compliance to the dispatch protocols. That's one of the things that makes you a credentialed dispatch center, of course, is your dispatchers have to follow to the letter. And if you don't, then obviously you're legally not in his comfort zone. This system is trying to rank order chief complaints of callers, of requesting parties. Do I need a single resource? Do I need multiple resources? Should they go cold? Should they go hot? Do they just need basic life support? Do they need advanced life support? It's this kind of nonlinear thing that's going on to try to stretch these patients out and, again, economize our resources. This chart simply shows if you just follow the line up, it's going from 1.4 to 17.2 on the right. What that means is as you go from MPDS's Category A to Category E, the chances of finding an acute status patient, somebody who's going to come back to the hospital lights and sirens, goes from 1% to 17%. So that tells you that there's some predictive accuracy, but not great. Okay, that's the best you can expect as you send out the door. But even on an E-level call, which is the high life-threatening situation, you're not going to find life threats all the time. We use 4 different levels of dispatch in San Diego. We try to stratify our resources so that level 1 gets an engine and an ambulance. Each one has a medic on board. Level 2 is just for special events like something going on at Qualcomm or a baby that's locked in a car. Level 3 is a no lights and sirens response with a medic on and ambulance only. And level 4 is a BLS ambulance that can get out there in a half hour because it's just somebody's got their hemorrhoids are bothering them, that type of thing. And for some reason they decide to call 911. Right? This gives you an idea. The pie chart shows you what we end up sending on. We send a lot of level 1 calls because we really try to play it safe. Other communities do it differently, but we send a lot of engine and ambulance responses because we feel that we really can't tell what is going on most of the time. This next slide, the response levels, gives you an idea that 78% of the calls actually went out with an engine and an ambulance. So about a quarter of our calls in any one year don't get the maximum response. Now the next slide, which is called transport codes, shows you what really comes back. In fact, if you look at the little slice of the pie that I pulled out that says code 10, those are the people that actually are lights and sirens returned to hospital. So for 100 patients that you dispatch on, only 8 are going to come back acute status. And again, that gives you the idea of what's in the mix of the system. And then I have a system that we use in San Diego that kind of screens and categorizes these calls based on what the medics think is going on. So it gives me some kind of a profile of what medical dispatch sent and then what they found. And that's the best we can do today because we are not yet linked to hospital discharge information. It's important to know, though, that by the end of this year, what's called NEMSIS 3.0, which is the National EMS Information System, will be vetted and fully incorporated and will be linking with hospital outcome data for the first time. And so in the near future, EMS systems will have real-time data about whether it really was a heart attack or whether it really was a stroke. So you can anticipate within the next 3 to 5 years much smarter systems that will have much more intelligent outcome data, and therefore dispatch can be much more, I think, intelligently managed. This picture is supposedly the first 911 call ever answered in Alabama, back in the United States. What are the challenges that we face? Process delays, naturally. The handoff from CHP to PSAP to secondary service answering point is a very critical thing. Language barriers are another delay. We have these currently, we have processes that take quite a bit of time to hand off. You guys know this. One of the major things is the accuracy of the requesting party. If it's a first-party call, I can believe you. If it's a second-party call, my wife's got this. If it's a third-party call, there's a guy in the parking lot. If there's a fourth-party call, which is not unusual, it's the Border Patrol saying there's an ambulance from Mexico supposedly coming with a guy who's supposedly got this. The border is the busiest response address in the city of San Diego. Believe it or not, that's the #1 address that we respond to. So it's all imprecise information. It's fourth-party information most of the time. That's the way it goes. So naturally, the protocols, as I alluded to, can't be built today, but will be in the future on better science, because we'll know when we send on motor vehicle accident, we're coming back with real information that says that's a high probability motor vehicle accident. It's a high probability of a heart attack, but we're not right there right now. And so currently, obviously, we can't harness the new technology of 911. That's why you guys are doing this. So what we end up doing today is we have this kind of a balance. You know, we have to send a lot of resources in order to make sure we don't make a miss. The worst thing 911 can do today is to send too few resources and end up getting interviewed by Ted Koppel on Nightline about why did you do that. And so that's what forces you to not be able to make an error. Okay, let's just talk about a couple, 3 quick examples. Sudden cardiac arrest. We know that survival is related to the chain of survival that the American Heart Association has created. You know, immediate recognition, early CPR, rapid defib, early arrival of advanced life support, and then the last new link is the hospital's integrated post-cardiac care. And if any one of those things falls apart, and here's the clock that we own, from collapse to recognition, to call, to PSAP, to secondary, to the institution of CPR, which, remember, many people, only a third of people in the United States will do bystander CPR. It's critical that be done. If it's not done, within 4 minutes, the patient's basically dead. In San Diego, no survivors in 1,700 people if somebody didn't start bystander CPR. Who owns that? Telephone dispatch, really, to get these people to do this. So it's really important that we get that started right now, that we recognize there's a cardiac arrest going on, and get the dispatcher to do this. And of course, all these other elements till we get to the hospital, this clock is ticking. Now this graph right here shows the decay curve of survival, right? It's basically, it's just drilling down, 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 and many people just simply say about every 60 seconds goes by, the chances of survival decrease by 10%. 10%. So the clock from when the 911 call comes until the patient is shocked out of the rhythm, there are only 2 things that will interrupt this. One is if you administer CPR, which therefore it's critical that the dispatchers recognize cardiac arrest and initiate this treatment. And if you can get a defibrillator at the scene, you can actually flatten the curve. So new technologies have got to be able to find where's the AED. The 911 system has got to recognize where it is and get somebody to go get it. The challenges, again, lay people don't know what cardiac arrest is. We have a hard time routing people. There are delays in the queue, of course, and then just CAD interconnectivity. So my PSAP is San Diego PD, and we have no connectivity. We have no way to kind of measure the times from police to San Diego Fire to know what the call time is unless we go back individually. There's no electronic link, and that, of course, has to go away. And we know that California is trying to connect all of the PSAPs already, but I think that this is important that when you think, like, why are all the survivals in these major cities that are totally committed to cardiac arrest as much as 3-fold different? Because they can't be that, people can't be that much healthier in Seattle than they are in Iowa or Dallas necessarily, although you may differ. One of the unwritten things I think about this is what's the process time through the dispatch? None of the cardiac arrest studies ever measure what's really going on in the communications piece. And if your system is 90 seconds slower than somebody else's, your survival rate will be 15% worse. And so I think a lot of cardiac arrest researchers believe that the hidden problem in some communities' survival from cardiac arrest may rely on poor transit times of the call. It's not the medics that are at fault, it's not the health of the people, but it may be the comm centers. So here are our challenges. You know, we've got to recognize things like agonal breathing. And for those of you that know how this works these days, we have new sophisticated techniques that allow dispatchers to count the breaths and then activate dispatch. You know, and being better informed about that will only help. Therefore, I mean, you either get telephone CPR or you don't. And it's critical that it be done. Let me just move ahead. Now, here's another thing, again, just to show you. This is a paper that was published that shows how many emergency dispatches occurred per cardiac arrest. This pie chart shows all the different ways that cardiac arrests get assigned by dispatchers in very good systems. They come in as unconscious, breathing, chest pain, seizures. But when the medics get there, guess what? These people are in cardiac arrest. So it gives you an idea that if communities are going to get better, they have got to get better in dispatch in terms of identifying what's going on. And any kind of resource, next-gen resource that brings that will obviously be a benefit to society. This slide just shows you, not to get into the weeds on this, but these three major studies provide evidence of the survival benefit of telephone CPR. It's unequivocal that when telephone CPR is administered by dispatchers, that people's lives are saved. And I was the subject matter expert on this at the World Conference this past year when we redesigned all the new CPR rules. My topic was telephone CPR, and it's unequivocal we need to be really good at this. This is another study that shows training is critical. If you have better training in recognition, these 5 studies all show significantly improved survival. So communities have got to be really capable at this. Now, one of the things is, and you may know about these already, is that there are these new devices that are hopefully going to push telephone instructions to people so that they can do it better. So you've got already apps that are out there. These things are going to be coming by the dozens, and it'll get better over time. Don't read any of these. Basically, just keep this as reference. There are at least 4 studies in the literature that show if telephone CPR by dispatchers is given with interactivity between the caller. In other words, you're in a dispatch center and you can see somebody live with a handheld and you can actually video identify what they're doing. The dispatcher can better tell somebody how to do CPR. And so video cell phone technology will definitely be coming in the near future where dispatchers will be seeing people, no, you're not pushing deep enough, you're not pushing fast enough, let's do it better. That's all been demonstrated in mannequins, and in the near future, dispatch will be doing this. And then perhaps you've seen, there are several of these out there. This is an iPhone app that identifies where the AEDs in your community. In fact, you can actually, college kids go out and they do this, they search and they find all the AEDs, they go into a Google map. The Google map then informs the community where's the AED. And future 911 centers will be finding the closest person that is signed up to be able to become a rescuer in the event there's an emergency in his near vicinity. And that type of stuff is all coming. So will police officers have maps of these kinds of things so that they can go get the AED and bring it into the cardiac arrest, so that there's simultaneous geolocation of these devices that are the critical thing. This type of stuff right here. Another example, here's downtown San Diego. We'd love to map the gas lamp quarter of San Diego. Where is every single AED so a cop inbound can go get that device if somebody else can't do it. This is some interesting stuff too. One of my fellows, John Serra, geolocated every cardiac arrest in the city of San Diego using the CAD data, right? This is all lat longe data. And what we did then is we looked at the communities. We're doing public health here now. We found communities where nobody was getting CPR nearly often enough compared to the rest of the communities. So this is a new thing that dispatch will get involved with, using CAD data to geolocate public health ideas that require specific areas of intervention in community. And I literally met with a city council member yesterday and their staff to talk about how can we inform and specifically target. And this is using FireCom data. So this type of stuff, it could be cardiac arrests, it could be drug overdoses. CAD data will be useful for public health purposes. Now this is really out of the box, but you should understand that at the meeting I was at yesterday, West Wireless, in another presentation, we're all going to routers. All of our engines are going to soon have these routers that will accept all kinds of broadband technology. Pre-hospital ultrasound is very coming in the near future. How will this impact pre-hospital or the comm center? I don't know, but there's certainly dragging down data from CAD will be a part of this whole thing so that, like the military does, they can put an ultrasound machine on and see if a guy's been shot, whether he's bleeding to death or not. This will be transmitted to a comm center someplace, okay? It'll be a doctor someplace getting it. He could be at the comm center. The doctor could be sitting at dispatch, or he could be off-site. So, heart attack. Same thing goes. Here's a guy having a heart attack. That electrocardiogram tells me he's having a heart attack. I can see the image, but it's better if I see it than if just the machine is telling the medic that he's having a heart attack. So one of the major projects we're involved in is pulling down these patients and then getting this information and then more intelligently sending people to the right facilities that can deal with it. We will be better informed when we can link those real numbers with dispatch so that we can refine the questions that we want to ask to identify who's really having a heart attack. And believe it or not, these devices will be handheld. I bet you'll be able to do your own electrocardiogram in 5 years and send it to somebody if you're having chest pain, and the machine's going to tell you whether you're having a heart attack or not. So let me skip past that slide. In the systems of care since 2004, this is a slide, very busy, from the American College of Cardiology, talking about the 90-minute time that we want in any community from when you have chest pain to when we get you in a cardiac cath lab and open up your coronary artery. Now, what are they looking at in terms of time? It's 90 minutes. When are they going to start the clock in the near future? Right there, right when the dispatch call is answered. True performance of a community begins at the moment the phone rings. And so the cardiologists are even getting in the game going, oh, wow, we really own dispatch, don't we? Yes, we do. That's all part of when the guy's his heart muscle started dying. And so just to give you an idea that the cardiologists and emergency physicians are all looking at the importance of the process time even in dispatch for medical emergencies. So we have so many different challenges here. One of them, I'll just jump to the bottom, complex conditions and devices. We have many pacemakers, automatic defibrillators, left ventricular assist devices. This is a left ventricular assist device. This device literally pumps blood around your heart. It may vary in the next 3 years. It may replace cardiac transplant for a majority of patients. These are so efficient now, you may not actually see transplanted patients. Now, to give you an idea, that guy has one, okay? So that's what I'm talking about. These devices, which are complicated, we need to know where they are, and we need to have that in-premise information, and people have to be informed. If they go wrong, what do we do? How do we connect people? All this sort of stuff is all technologically being driven. Last, stroke. Many challenges very similar to heart attack in terms of recognizing who's having a stroke and who isn't. I'll skip by the medical alert alarms. This is a study that one of my fellows did 3 years ago, looking at the accuracy of the emergency medical dispatcher, the sensitivity, and the positive predictive value of the current protocols. You can see that the predictive value of the protocols is 42%. It's almost a flip of the coin today at dispatch. Is this person who has a time-critical disease that needs to get in a facility and get their artery open, can dispatchers figure out if he's having a stroke? Not really. Can the medics? No, they can't. They're not that good at it either. What is going to enable that is telemedicine. And so a study that was done by a guy at UCSD 3 years ago showed unequivocally that the ability to see a person with a video is better than being on the telephone with them in terms of identifying what's really the matter. And so dispatch centers, if we're going to make these things better in the next 10, 20 years, we're going to be informing people with sight, with line of care to figure out what's the matter with this guy if the system is going to get more cost-effective. And there's a physician who visited me from Japan. They're creating the first center in Japan with federal research funds to develop this very kind of thing, a centralized command and control system that will be a smart system to better assign resources. So it may sound a little weird today, but this kind of ultrasound to kind of shine on somebody's brain, these devices can actually identify with a little probe on your temple that you're having a stroke, and even more amazingly, you could squirt stuff into this guy. Let's say you're the doctor at the other end of this transmitted signal. You could say, now give him the stuff, and that thing will vibrate ultrasonically, that stuff, and it'll start to break the clot apart. So maybe if you're in a rural area and you're having a stroke, you could actually begin treatment in the field. So this kind of stuff is not necessarily at dispatch, but it links to dispatch. So the whole concept of online control is going to change. What the medics get by their radio, who, if you have systems like we do where you've got nurses that are giving instructions, those things are probably going to give way when you're moving into this era where data is going to be delivered by cell phone. And all of our medics are moving into wireless cell phone technology in San Diego. And this is my joke here, there's House. You know, he's in a comm center. He's providing medical direction to this guy who's got an LVAD. So that could be on-site or off-site. In New York City today, they have one doctor running all the medic calls in 6 boroughs for 8 million people. One physician provides all the medical command and control. They have 3 medics. The medics do everything on their own until they need advice, and then they call one doctor. And they pay somebody to sit in a comm center out in Queens and basically answer questions what the medics should do or shouldn't. Do you go to that hospital? Do you go to that hospital? That's where New York City's at. So it's not that far-fetched. You could even have one center in Sacramento doing it for the whole state if you wanted to. Last, this is really an exciting thing in San Diego. The future of information technology, which all CAD systems will tie into, is the National Health Information System. It's the cloud computing of the nation. The new information technologies will all go up into the cloud to find the data that you need, or they will come into our CAD and grab the information that they need, such that, let's say you're going to such and such an address, okay? Probabilistically, we want our paramedics to know by the time you get there, it is Mary Smith, she is a patient at Sharp Memorial Hospital, she is in cardiac arrest, she has paperwork on file electronically at another hospital that we bring in through CAD that says she doesn't want CPR done. Okay? So we want to inform the medics with information, and conversely, we want to share information back to the hospitals and their doctors. And so this entire interface of electronics going into the cloud and having what we call, the health information exchanges. And that's what this kind of depicts here. You see that there's a health information exchange in San Diego, and you've got hospitals and public health and EMS and systems and groups and clinics, and then they're all going in and out of the cloud on an as-needed basis to go gather data. And that's really what I see as a holistic kind of a view of the information system. And when the Assistant Secretary of Health from the federal government, the Obama Health Reform Plan, comes to San Diego and says, this is it, you guys are on the right track, and the Chief Technology Officer that's creating these systems, I think this is really where these guys are going. And all you got to do is then put all the Band-Aids on patients. They're going to be sensing devices and pushing this information to doctors and doctors to EMS and this whole thing. This is really where we're at. We have to be able to accept all this kind of information. And 911 is just a piece, clearly. But, we have to be able to integrate with all these other things that are coming in healthcare. So I'd be glad to take a couple questions. Otherwise, if anybody has a stubbed toenail, I'll be on duty in 30 minutes at UCSD in the ER. Thanks a lot for having me.
I'm sorry.
Sure.
Actually, it was just a comment in response to one of your comments in your presentation. I just sent you an email with, I'm from CHP, and I sent you an email with the statistics for our call answering, how many calls come in, how they're processed.
Please. Yeah, great.
The duration of the calls, how quickly they're answered and processed. So to kind of answer your question, how we're doing, I just sent that to you, so you can take a look. And if you wanted to discuss any of it, you're welcome to give me a call or talk to Lieutenant Paredes. He's the commander of the comm center here in San Diego. It's
great, and I'm really excited that because I have friends, that are medical directors all throughout the state, and everybody is kind of still at this point, of kind of ricochets of 911 calls and where they go. If you're close to the freeway, or if you're on the campus and your PSAP is over here, and I know it's getting better, but I think it's clearly something that technology will cure over time.
If I could, Doctor, very, very encouraged by the advancement in technology as San Diego's participating in this. But I want to offer, just for your consideration and something to think about, that, and maybe it's the way that I interpreted the presentation, our comm centers are doing more than just EMS.
Oh, I'm the medical director of the whole show. I know. We're doing fire over there.
No, I think what I mean is the majority of communication centers in the state are the 911 answering point for everything, including criminal activity.
Oh, yeah.
And calls for service. So just for consideration to think about is that as the technology moves forward, let's also look at jumping the technology of this information being as quickly as possible routed to the first responder, as opposed to setting a framework of training for the dispatcher. Because the way that I heard it sounded like we've got to add additional training and the ability to interpret all of this data and information coming into the comm center to the dispatchers. And quite candidly right now, it's a daunting task, as I'm sure you know as the medical director, just to do the QEs for the dispatchers on pre-arrival instructions, just to get to that point, with all of the other things that we're keeping them up to speed on. If we're investing the money in the technology and the end user, i.e. the paramedic, who's going to be the first responder dealing with that person, or it may be the police officer, let's figure out the way to get that as quickly as possible to the field and not have to have as much interpretation at the comm center as I understood the presentation to suggest.
I didn't mean to portray that, and I think that's an excellent point. In fact, the one thing that I made specific to the secretary yesterday is you have to think of providers as police officers, firefighters, and also people who work at the rescue mission and the homeless shelters. In other words, healthcare moves into the community, and it doesn't remain in hospitals and doctors' offices. And so I couldn't agree more with you in terms of kind of pushing the information out as fast, because I don't really see that you need to have, you know, a PhD or an MD to be able to work in a dispatch center in the future. And in fact, the other thing that I think is interesting to think about is accountable care organizations are the big topic now, right? Is that you take care of your own like Kaiser does. But really what's moving next, and this is something that's kind of a very forward thought, but I think it really is getting some purchase in an accountable care community. In other words, whether you have Sharp, Scripps, UCSD, or Kaiser in your community, they're all responsible for the whole community. And so literally, if you think outside the box, they all have to drive down cost. They all have to give care better. Why aren't they investing in a 911 system in the future? If it all costs everybody something and everybody's got skin in the game in 5 years, then the whole transformation of who runs and operates and contributes to comm centers might change. It really might not be just the responsibility of police or fire or whatever, but it might be a more collaborative kind of a concept where everybody wants to make this better, and you might have a different kinds of disciplines in dispatch centers even. I'm just thinking out of the box. I don't predict this, but I think to really get where we've got to go in terms of driving healthcare costs down and provide better care, and police and fire, that the silos that we've all kind of been assigned into are going to morph into something a little bit more integrative over time. And I think that, you know, you might very well see hospital CEOs actually helping in dispatch centers in 10 years or 5 years. So I couldn't agree more with you. I don't want to have our people sitting there going da-da-da-da-da-da, you know, for 30 seconds. If I showed you my process times, you know, and we're trying to make that 45-second dispatch, you know, we just can't sit there and look at ultrasounds. But I'm saying that there'll be parallel paths, and we should just understand that all this other stuff is coming. And, you know, we're informing 911, we're using Twitter, we're trying to get cell phones, we're trying to have alternate things to help us with what our part is, but we are part of this aggregated, much larger picture that's going on in health and in public safety in general. So I'm totally with you, Chief. Yeah.
Mrs. Wong? Peter Bryan, representing the California Fire Chiefs Association, and certainly I'm a huge proponent and supporter of any pre-hospital care EMS, whether it's STEMI programs or whether it's certainly pre-hospital arrival instructions. I know that's outside the scope of the 911 board. My concern is that as we look at today's technology, and certainly at the one of the public meetings we heard about the automobile wireless systems and how they take that call and what they do with that call. That certainly, I think, should be some of the scope of the 911 advisory board is what happens to that call. Once it's been addressed at the appropriate PSAP or PSAPs, who provides that pre-hospital care certainly is going to be directed and then the authority of either the state EMS authority or the local LEMSs, the local EMS agency. I think our scope should be what happens to that call, that information when somebody either tries to text 911 or call 911 or somehow tries to activate the 911 system, and what happens to that call. Some of my concerns, certainly from the public meetings with the automobile systems, is as it changes from a hardline 911 or a wireless 911, and it goes to automobiles or it goes to data or it goes to next gen, is what happens to that call? And I want it to get to the primary and the secondary PSAP as quickly, uninterrupted as it can. And then once the things are on the road and the wheels are turning, law enforcement and fire and EMS, then give that call or do something with that call. But what I heard from some of the presentation last at the public meetings was, okay, we're going to direct it to our center. We're going to take that call because you push the button in your car and we know what to do. I think if you change hardline or wireless 911, whether it's Verizon, AT&T, or any of the other providers in California, and you redirect that call other than to a PSAP, and the first person answering that call is not a PSAP operator, and some level, whether it's this board, the 911 office, certainly somebody ought to have review of what it is that next gen and this automotive phone dialing wireless systems are doing out there, because to slow that call down, to get the things rolling on the road, and then give it an appropriate pre-hospital care information, I think is a problem. And certainly, while we've got great programs out there, and there's about 2 or 3 pre-hospital care prioritization systems out there in the field, which are good programs, the question is what happens to that call, and I'll use the word call, when it leaves that particular device and somebody initiates some kind of request for care. And I see now, as we're looking at next gen and the automotive wireless systems, that there doesn't seem to be something, maybe the 911 office, something in California that's reviewing, you know, this is a different system, and it's not going directly to a PSAP, it's going someplace else. And years ago in California, we saw that with a PPO provider. And on the back of the medical card, it says, call us and we'll help you out. And we said in California, no, you call 911 when you have an emergency and you call your healthcare provider later. Stop slowing down the PSAPs and the wheels rolling on the street. And I think that's got to be a big focus. And I would love to entertain some legislation in California that says if it isn't wireless, if it isn't hardline, then you got to direct your request to that system through the 911 office if you're going to change where that call goes. And somehow I think the focus of the office and the board should be, if it's not going to a PSAP, who's reviewing where that call's going before it goes someplace else? And,
You know, and Peter,
but I strongly support any pre-hospital care, and we've saved lives with STEMI programs in our county. So raw for those, just don't change where the call's going.
Doctor, do you know if the systems like OnStar and that are participating in the NHIN?
That's a good question. I don't know that.
Because I think that's going to be the next gap. I think it's a precursor to what you're talking about, Peter, as far as saying we want to get it to the appropriate call center, ultimately, that's going to do pre-arrival and MPDS, whatever protocols are being used. But more importantly, the same questions that you have right now for some call-taking locations, if there's nothing to mandate that OnStar or, I'm just using that one. I can't remember the other one.
Automobile wireless services.
Yeah,
There's Fort Sync, ATX, and OnStar does go through, they do EMD protocol. They have been approved to do EMD protocol.
Yeah, what I'm talking about specifically, Lisa, though, is that the call data from them gets shared so that as you look at a geographical boundary, as you look at San Diego's system, and as the director, you want to say, okay, how are we improving this? And you find out, gee, you know what? Now that there's ATIS and OnStar and this, that, and the other has become standard in the cars over the next 5 years, and you're not seeing your times come down. Well,
It's kind of like MedAlert bracelets.
Yeah.
The call goes to South Carolina.
Right.
And then somebody calls us back.
Right.
Or your
alarm at home.
Yeah, I mean, it's nice
Yeah.
when it works, but I mean, unfortunately, you don't want a 3-minute delay in somebody who's having a difficult time breathing.
I just
agree.
think it'd be an additional person that should be at the table
I think that's
as
great.
you move forward with the NHIN.
Yeah.
And Lisa Hoffman,
I have to go, you guys. I'm sorry.
Okay.
Yeah, thank you very much for the presentation today.
So thank you for the brilliant observation, Chief Spiegel, about 911 dispatch centers. And just speaking from my perspective in San Francisco, we're one of the largest combined entities in the state. We do police, fire, and EMS. 80% of what we do is police, 80. 14% is medical, 6% is suppression. And of that 6%, only 1% is greater alarm structure fire. So, and we're a major metropolitan city with a lot of activity. We did 66,000 medicals last year alone. So we have a high volume. And I think before the state looks into perhaps entertains the idea of bringing hospitals into a next generation formula where they're actually answering calls, we have to consider what the larger perspective is. The volume of what most PSAPs do is public safety for police, not necessarily for fire or EMS. And not that I'm not saying that they're not doing a great job. I think the EMD protocols are fantastic. I would love to see more advanced work in that, but I am concerned about some of the products that I see coming onto the market that are impacting a lot of PSAPs. There are a lot of good programs out there that do identify where AEDs are, but that has to be tied into your CAD. Somebody has to do the work. Somebody physically has to go out and make sure that AED exists, that it's up to date, that it hasn't been used, destroyed, or moved, and that you know what counter at Macy's in the women's department it's actually residing in, not just that it's at Macy's in Union Square. Heck, that's like 4 blocks long. So, you know, there's a lot of work that goes behind that, and a lot of that is people work. So I'm concerned that there are a lot of programs that are developing. We can't stop the programs. We're just going to have to embrace them. But they do, on some level, require work by actual live people to go out and validate the information. One of the bigger concerns I have are things like location information. You're saying that you're going to have a hospital download information at Karen Wong's house that says Karen has a heart condition, these things. Well, what if Karen moved and didn't tell anybody? So these are some of the concerns that I have that I want to make sure if we're looking at embracing this, and I'm not opposed to it, is that we make sure that we recognize there's a lot of manpower. Computers can't do anything. I mean, everything. Physical bodies have to go out and physically validate the information. Somebody in the dispatch center, whether it's the IT person or an actual dispatcher, has to update the background files to make sure that that information is accurate and up to date. So the geo files have to match. So there's a lot more that goes into that, and that's all going to be tied to a GIS, I imagine.
Well, and I wanted to just respond to Peter's comments and your comments. First thing I want to tell you is I'm truly excited to hear the comments, because what is coming out of the public meetings are these discussions that we weren't having before. And these discussions are so important. There is so much going on out in the industry, and I think it became very apparent to everybody in the auto industry that they do have these call centers. And I'm not sure if everybody totally agrees that it's a good thing or a bad thing, but it's a discussion that we all have to have as we move toward next gen. And we do need to get legislation done, but we need to be able to frame that on what works best, and we need to gather this information. That's why I want to have Dr. Dunford here today, because what he's doing in the medical field is probably a little bit revolutionary, at least from what I've been looking into for California. And he's doing this, and he's saving lives, and it's a really, really good program. And so we need to understand everything that's out there, start having these discussions, and frame our legislation appropriately. I've also been having discussions with the FCC. They're struggling with this same issue on the national level. And we had an FCC representative out for a different conference last week or the week before, and I was able to spend quite a bit of time with him, and he's willing to come out to one of our board meetings to explain what's going on at the national level with and Next Gen 911, what some of the other states are doing, and how he sees some of the legislation going at the national level. So these discussions are happening everywhere, and they're very appropriate. So I'm really pleased that, if nothing else out of the public meetings, that we started to see and get feedback on what is actually going on. People are making these apps every day that will affect how 911 will work. And the public is going to be relying on them.
I think there's actually an expectation more than just reliance. I think there's a public perception and expectation that we can provide this. If Apple can invent it, we should be able to apply it.
Exactly. Exactly.
Ms. Wong, certainly, you know, we can't control, I mean, the public is going to control the information. What did I hear the other day? Twitter's got 2.4 million tweets a day. Astronomical. Nobody thought they'd get this social communication system getting that kind of business. But certainly, as we look at all this information, I really don't have any particular concern where the information flows. As long as information flow and sharing and where you've got your databases and all that is after the person on the end of the something or other, whether it's a computer, a tweeting device, says, is this a police, fire, or medical emergency? What's your location? What's your problem? What's your call back? identifier so that I can get to you and then share the info. But doggone it, don't allow other industries, automobile et al., to be able to slow that call down and not get it to a primary and a secondary PSAP and then share information. And I guess what I'd like to ask Mrs. Wong, the office, to do is, at one of our soon-coming meetings, is to tell us, okay, right now if you put in a hardline phone, it goes to 911. When you pick up a wireless phone, I think even a trashable one, you know, certainly Chief Chappelle could tell us, okay, you buy one of those for $50 and you throw it away, but when you dial 911, it goes to some place. Now, if you got any other way of starting a emergency response, you know, who regulates that? Because if the FCC can't regulate it in California, or won't, or the feds can't do it, the question is when all these people, including the automobile industry, says, we think we want to redirect that call, and so far nobody's controlling us. It's kind of like years ago we saw the air ambulance industry. Nobody controlled them. It was just a FAA and those kind of people that control it. Somebody has to regulate this creativeness that says we're going to regulate and direct where these calls go. And they can't not go to a PSAP to start with and then share the info. Somehow we got to know that. Please.
No, I totally agree. And
I know that.
Yeah, I mean, because this is all about making sure the person gets the help they need. And if the calls are all over the place and there's nobody out there on their way to help, then 911 has failed. And that's not what we can't go down that path. So we will be having meetings, and I'm really pleased that the public meetings are starting to create these conversations. I do need to get back on track with the board meeting, and we'll be talking about the public meetings a little bit later, so I'm hoping there will be further discussion. I'd like to, for the record, note that Peter Bryant and Chris Henshaw have joined the meeting. That was a little bit after roll call. And so I'd like to move down to approval of the December 2010 minutes.
Move approval, Spiegel.
Second by Brian.
I have a correction. On page 3, section C, Committee on Outage Notification Escalation, it's not NENA, it's CalEMA, the California Emergency Management Agency, not the National Emergency Number Association. So in both those instances, that needs to be changed to CalEMA instead of NENA.
Okay. Were there any other changes to the minutes? Okay.
Good catch.
Do we have a motion to approve the minutes with the changes? Yes?
So moved.
Second.
Okay. Minutes are adopted with the changes that were noted. Okay, we move on to unfinished business. The first on the list is the 911 division updates. So Carolyn Brown.
Good morning. I'll be providing the 911 updates today in Ryan's absence. And we'll start with just some general information relative to comments at the December meeting. In response to Peter Bryant's comment at the December 2010 meeting, a handout is included in your packet to illustrate the strategic plan goals and how they map to the phases identified in the Next Gen 911 roadmap. Also, in response to Chief Chappelle's comment at the December 2010 meeting, a handout was included in your packet to report on the 2011 statewide average abandoned call volume. The call statistics report shows a comparison of the average number of abandoned calls for the state, PSAPs, and CHP. And to note, since ECATS is a recently deployed product, not all the historical data has been converted. So we just went with the PSAPs that have been converted at this point, and we anticipate that historical data will be converted by the end of 2011. Also in your packet, we included as a reference a handout outlining the State 911 Advisory Board active committees, the state's active work groups, and the task force just identifying the members. Also, we were informed of some information regarding the creation of a new funding model by the California 911 Division. At this time, the division is not currently working on a new funding model. Assessing the cost and funding for Next Gen 911 will be a part of the proposed roadmap and a part of the phases. The identified areas in the roadmap include governance, operations, strategic and transition planning, managed services, policies, cybersecurity applications, data, and the IP-enabled network. The California 911 Division is currently working with L.R. Kimball on a cost of magnitude report for Next Gen 911 and will share the information with the Long Range Planning Committee once it is completed. The anticipated completion timeframe is late April. The California 911 Division is also working with L.R. Kimball on regulatory considerations for California's 911 strategic plan and will share that information with the Long Range Planning Committee once it's completed, and that is also expected to be in late April. We are also working on a new RFP for the 911 telephone systems and services. The current contract expires in September of this year, so we're right in the middle of that procurement effort. Ryan Doolin is actively working with the County Coordinator Task Force on finalizing the charter. He plans to target an approval of the charter by the time he meets with the task force at the Calnina Quarterly on April 28th. Okay, on the Enhanced 911 Grant Project, we have a consulting firm, L.R. Kimball, providing project management for that initiative. And there was a fourth Butte CAL FIRE was added to the California 911 Hosted Solution project up in the north part of the state, and that PSAP went live on March 2nd. An article on that project was included in the February 2011 911 newsletter. And project fact sheets were created, are in final review with Ryan and Karen, and the division anticipates having these fact sheets posted by mid-April on our website. There's an outage report in your packet, and we have added a column to indicate the type of outage it is in order to identify patterns over time. Standard descriptions of the types has not yet been determined, but we'll be working on how to, what to call each of the different types. Also included in your packet is the red fact sheet with corrected information. The first bullet under key information is changed to reflect the correct percentage of 42.4% for 2007, and I believe that was incorrect in the last handout. Okay. Thank you.
Thank you.
Were there any questions?
Yes, follow-up question. Peter Bryant. Carolyn, thank you very much for what I think is this strategic plan goal mapping handout number 5.
Right.
And what I heard you say was you mentioned the month of April. So between you and Mrs. Wong, are we envisioning that most of the goals and then the Next Gen 911 roadmap will at least by April have some kind of a long-range timeline? And of particular interest is, and I would hate to bring this up at a time when I think our governor is probably asking the legislature to consider a public vote on taxes, but will that timeline include a look at the tariff level for Next Gen and the hardware, software, everything that goes into that? I guess I'm trying to look at the big long-range timeline that says, okay, we have these goals, we have a next-gen roadmap, and we think by this frame timeline, we're going to probably have this thing moving along pretty good, including a look at the tariff. But I'm hoping maybe you can clarify that, please. Thank you.
It will be, it all rolls up at the same time frame because we will have cost order of magnitude developed at the same time. And until we know roughly what the cost of this infrastructure is going to be, it's hard to know if the tariff is at the right level or not. So yes, it all rolls up at the same time.
Thank you again, Carolyn. Thank you.
April's going to be a pretty big month for all of us.
Any other questions? Thank you.
Okay, now report County Coordinator Task Force. Hanan Harb.
I asked if I could do it from there, and I was told no. Karen. I'm Hanan Harb, member of the County Coordinator Task Force, so I was told that I was doing a report here. Since the last advisory board meeting, we've been working on several things. We held a county coordinator forum after the county annual conference. We had about 58 attendees, made up of county coordinators and telcos. During the forum, we had the opportunity to bring up different issues within the different counties, network with other county coordinators, and use the expertise of the telcos and other county coordinators to get resolutions. There was also training for the 911 IM system, which is what is used by the county coordinators to update the MSAG data. It was done by both of the major telcos, and we also had ECATS personnel available for questions and a discussion. We've also been working with the State 911 Office, like Carolyn said, to finalize the charter for the County Coordinator Task Force. There's been some modifications made based on input and discussion with the state. We're hoping to have a final charter soon. We're waiting to hear back from Ryan on that. 4 of the County Coordinator Task Force members are involved, or were involved with organizing and presenting at the public meetings. So they're getting involved in quite a few different things. 2 of the members are members of the State 911 Technical Review Work Group, currently working on issue papers for a variety of different emerging technologies. And 2 of the members are still participating in the MLTS project with the CPUC. So we continue to meet regularly and look for things to do to help the state.
Were there any questions? I just have one comment. We really appreciate the County Coordinator Task Force, and you have been a big help with the office, and just the interaction that we're having is a huge improvement. So I really appreciate all that you guys have done.
Thank you.
Okay, the Committee on Outage Notification and Escalation.
There's been no activity.
The Committee on PSAP Consolidation and Host.
Mrs. Wong,
Oh, I'm sorry.
I'm sorry, I didn't jump in fast enough on that. If I recall from some conversation talking about outage notification, there was maybe a conversation or a discussion on a proposal other than Cal EMA, and I may have missed that by not attending one meeting, so I'm hoping that, has that been wrapped up? Is that coming to fruition? If a thing dies, do we know how that?
Okay, the office is working on a proposal on how we can cover this. Unfortunately, we have quite a few vacancies right now, and we're going through the process of the freeze exemptions to get some staff hired. And as soon as we're able to see how many staff we can get hired, hopefully we can provide the proposal to the board. Until I have adequate staff, I can't put the proposal forward. It has not died.
But it's not progressing to the Cal EMA side of the shop, is that correct?
No, this is a separate proposal. We're hoping to be able to provide coverage internally in the office.
And can I ask, not to throw any state organization under the bus, did Cal EMA just say, we don't know, we don't care, we can't do it? What was their final response?
The last time I spoke with Cal EMA, they were very supportive of having the calls come into the warning center and thought it was a good idea. We were going to start talking about if there would be any additional resources, and unfortunately the undersecretary left. And the last time I had the conversation, they were waiting for some more appointments in Cal EMA to begin the discussions again.
And I know we had requested Cal EMA to come to either a committee meeting or a board meeting and say, hey, we'd love to do this, and unless I missed it, they never showed.
We had a whole report that was put together, and we did forward that to Cal EMA, and I did speak with the the undersecretary at the time regarding that, and again, they read it.
They didn't show up, though.
No, they did not show
Okay,
up.
Thank you.
Okay.
I'll throw them under the bus so you don't have to. Okay. Please, continue with that then, because I think certainly from the perception of some of us that were on the committee and discussing that was, if and when it dies, the primaries, then hopefully they'll let the secondaries know. But the primaries need to know that. So thank you for picking up that ball if other state agencies couldn't do that, and thank you.
But we do have new people seated now, so it might be worth a second run.
I agree. I think we've been
Those
going at
appointments have
this
been made.
for 4 years, actually, I believe. Am I wrong, Chris?
No.
It seems like a relatively simple process, and we're all one mission, one government, but apparently we can't talk to each other, so.
I just wanted to find out because I knew that there was some stuff going and it just never came back. And again, unless I missed it, we were waiting for a Cal EMA rep to come to the board to explain, and I think it was answered. They didn't come, so.
Okay. I will commit to having a Cal EMA representative here or being able to come back and say that it won't be going through Cal EMA.
Yeah, give yourself an out, so, okay.
I have to have two choices there.
Thank you.
By the next board meeting. Okay, were there any other questions before we move on to the PSAP consolidation and hosted solutions? Okay.
There's nothing further. That still is where it stands from December of 2010. We submitted our paper. It was accepted by the board in January, and it's been hopefully given to the consultant to use.
And it has been given to the consultant. And there was a proposal that we would like to the board to consider, is that we're going to recommend that we sunset the committee on the PSAP consolidation and hosted solutions and bring that into the long-range planning committee because it's all going to the same source. So the long-range planning committee will end up having that, the PSAP consolidation and hosted solutions, as well as looking at long-range as we move down next-gen 911.
I thought we had also discussed just using that as a subcommittee for that long range if they wanted to come back to that committee for direction.
I'm okay with that also. This was a proposal because we haven't had any more activity and it's going to roll into the long range. So if we want to keep this proposal of it still staying intact as a subcommittee, I'm good with that too. Okay, we will leave everything intact as it is right now as a subcommittee.
I mean, I'm fine either way. I just think we were worried about having too many members on one committee, and so we were going to keep that as a subcommittee that they could go to for technical advice or other resources if they needed it.
Okay, and I guess what I'm proposing is that we sunset the hosted solution and PSAP consolidation committee, just totally sunset them, move this issue to the long-range planning committee, and as always, the long-range planning committee can reach out to whoever they need to for technical support. That's the proposal.
I'm fine with that, but I would also like to suggest that we do the same with the GIS committee, and that we turn the long-range planning committee, the GIS committee, and the PSAP and consolidation committee into a next-gen committee. Because all of these items are going to become inherent in the next-gen movement and moving on to that platform, and they're all interrelated to each other when it comes to a relationship with that platform. So my suggestion would be to consolidate those three committees into a single committee, name the new committee the Next-Gen 911 Committee.
I would support that.
Okay, do we have a motion?
I'll make that motion.
Do we have a second?
I'll second.
You have some discussion?
Is there discussion?
I'm certainly not opposed to it, and I applaud those that are involved in multiple committees at looking at trying to get meetings down to a little more centric. But I really think that the next-gen issues is at the forefront of what this entire group is challenged with as we move forward. And as difficult as it is to get everybody together, I think that it's important that every member of this panel be involved in the next gen processes and dialogue. It's important, and I've got something on the agenda a little bit later to speak to this on, but I think that it's important that the constituents represented by the multidisciplines on the board here are all actively involved in that, and I don't want to minimize the efforts of a subcommittee. I just think it's extremely important that everybody participate in it. So I offer that for your consideration.
Mrs. Wong, Peter Bryan, what I heard originally was wrapping this together, and that was long-range GIS consolidation and hosted solutions. Listening to Chief Spiegel, I'm thinking, okay, next gen is the big thing out there. Not that the others aren't, but there's certainly components of that. I guess maybe, Chris, because it was your motion, is I think the first concept that I thought maybe you mentioned was, okay, bring those all under the long range, or maybe Mrs. Wong, but somehow bring that together, because I do think Chief Spiegel's right, that next gen is such a big thing that all the disciplines in the 911 board should be there. And those other little components, important as they are, might be better under that long range, even if it got retitled, but certainly those could be merged there, so.
It wouldn't next gen be long range? You know, maybe we're almost saying the same thing, unless there are other parts of the 911 program outside of next gen that would, you know, be looked at as well. But maybe they're the same committee.
But I think what I heard from Chief Spiegel is that everyone on the board would need to be part of the Next Gen 911 committee. The board would be the committee.
For that project, I think we all need to be here.
Your down is on.
Can you hear me now? I think I agree with Chief Spiegel with the Next Generation 911 that we all need to be at the table and have input to that, because we all have come from different aspects of the Next Generation 911 system. But I do think under the long-range planning that these two other subcommittees can be rolled up into the long-range planning so that they're incorporated and we're not doing work that may be counteracting someone else's work as we move forward now with a consultant. And however, we need to probably add some of these other members onto the long-range planning without having a quorum, or having an ad hoc where they, you know, that we keep these as the ad hoc committees that they can go to for reference.
That satisfies my concern.
Okay, so I guess I'm withdrawing my motion.
Peter Bryan, I'd support that.
I have no idea where the hell we just went.
And Peter Bryan, again, I think my concern was I supported the concept of those individual subcommittees because we were able to move some work product together and bring it back and let the board look at it. And I think there's still some need for those things. But if the whole board would have had to do that, I don't know, we could have moved that product along fast enough. So I would encourage that, because I think those small subcomponents still could be under long range. And the next gen is the big thing that the whole board should be involved in. But if you would be willing, I would certainly support that. But otherwise, I think there's still a need for just moving the little ones into one.
Lisa Hoffman, I have a concern that if we make next gen with the entire board, then we can only do it quarterly when we have a public forum, right? Because we have to have it has to be a public meeting if we're all together, right?
If we're all together, it has to be a public meeting, and my caution in having this quarterly is we will never get it done.
That's what my biggest concern was.
So we will have to have probably a board meeting a month at a minimum, because we will be meeting quite often on next gen. And so that's why I need to kind of get some clarification. Are we suggesting that the entire board be the Next Gen Committee, or are we suggesting that we continue with the Long Range Planning Committee? We could rename it Next Gen 911 Committee, and having the GIS and the Consolidated PSAP committees be subcommittees of that component. Did I say that clear enough?
I think that makes more sense. I mean, I honestly don't think we're going to ever be able to get together, all of us, every month. I mean, maybe it will happen, but I don't know. And I am concerned that if we have to make it a public meeting, there's a lot of work that goes behind that, and that's why it's easier to not have a quorum and have a core group of people working on it and then bring it to the entire board to decide if we're going in the right direction or not. So I truly am just concerned that it's going to linger out there like the Cal-EMA thing for the last 4 years and nothing will ever happen.
And we're not going to allow that, so, because we as, in the 911 office, we have to move this forward. And we want the board to be a part of us moving it forward. But if we wait for quarterly meetings, we get really disconnected. And I don't want that to happen.
And then I just have one more comment. We in the 911 industry have to move it forward because we're getting killed by all this technology that we're not able to translate into usable data. So we can't wait any longer. I mean, it seems like every day I turn around, there's some new piece of technology that somebody's on the news saying, hey, guess what? Dispatch centers are going to be using this from now on. If we wait too long, I mean, we're already so far behind the curve. If we wait too long, we're going to sink in quicksand. So I just want to make sure that doesn't happen. So whatever the board's decision is fine. I just caution that I don't think we should go forward with an entire board committee because I think it will belabor the process.
Well, I'll go back and try and make some clarification. I'm not suggesting that the entire board be a committee. But what I am suggesting is that we all have responsibilities to our representative groups to be weighing in on Next Gen 911. So how that gets solved, I really don't care. If that means that we have to meet once a month for the next 6 months, with this crucial an issue facing us in a roadmap that's going to be developed, then maybe that's the effort that has to be made. That's part of the commitment of what we're doing here on the board. It doesn't take away anything, Chris, from what you were suggesting, and I understand the rolling up of these other committees in that. But Next Gen is like throwing that in as the umbrella of everything, where I think we're looking at the GIS committee and long-range planning. Long-range planning has had Next Gen in it, but it's also had some other things in it that Next Gen may or may not be looking at because we don't know yet.
Mm-hmm. Mm-hmm.
I'm not clear if all of you are. I've attended one of the community public hearings on Next Gen, but I still don't have a vision of what's being done on behalf of our contractor to help us form what the vision of Next Gen is going to be. I couldn't tell you what all it's going to be inclusive of. I can tell you the things that have been presented there that somebody said, oh, hey, I'm with this mobile application, and we want to be able to have this integrate into Next Gen, and we heard from the good doctor on the things he'd like to see, and in a few minutes here I'm going to offer some things that for whatever reason hasn't been considered yet. So I don't have a good vision of that, and I think it's the primary responsibility of this entire board to be looking at that so that we're sure and we don't face a situation on behalf of the state here in another year, 2 years, when one of our representative groups comes into the state and says, oh, stop, you left this out. And the state's going to turn around and say, well, you had a representative on this board. What up?
And then Lisa Hoffman, Karen, I just want to make sure we consider that we still haven't been able to do anything with the GIS because the person hasn't been replaced yet. So we've actually made no progress on that whatsoever. And I think GIS is going to be the biggest component of Next Gen.
I have updates on GIS. We hadn't gotten there, so I didn't give them yet. But I can give them to you right now. Scott Gregory has been hired with the technology agency as our GIS. I don't think I have his title here. He'll be the deputy director for the GIS component. And the 911 office has met with him already and I have had some conversations with him. He's really excited to start helping us with 911. And so we will be setting up, well, what I was going to have set up a committee for GIS, but we will look at however we're going to do that. But he's very well qualified and very competent. We're very excited to have him on board.
So as a matter of protocol or procedure, if I could recommend to the chair and if the motion maker will agree to it, how about if we table the motion to the last action of the meeting, get through everything else, get a scope of what all else we've got ahead of us, and then if your motion, you still want your motion to stand, call for the question at that time when we've got all of the information of the rest of the stuff that's coming forth in the meeting.
That's fine.
Okay. Okay, and does everybody want to take a 10-minute break, or do we want to continue moving forward? I always like to continue moving forward, but I plow through meetings, and I want to be sensitive to everyone else.
I'm okay.
Okay. Okay, we'll continue. New business. Wait a minute, I think, yep, I got through everything. New business, I wanted to talk with everybody just briefly regarding the cell phone interdiction in the California state prisons. There's been at least one contractor, vendor out there, possibly more, that has reached out to at least 2 of the advisory board members regarding the cell phone interdiction and the inmates that have illegal cell phones with them right now in prisons. A huge issue in the state prisons. And I wanted to kind of go over a little bit of what the project is, what they're looking at, and then what it will mean to 911, just to get everybody on the same page. The California Department of Corrections and Rehabilitation is looking at several different approaches on getting the cell phones out of the prisons, or at least disabling the cell phones. One of the technological solutions they're looking at is managed access. And managed access basically deploys a secure cellular umbrella over a specific area. It's a cell phone tower that actually will have a higher power than all the other transmissions in that prison area. And they will have to program in official cell phones, like if the warden has a cell phone, the warden's telephone number would be programmed into this system, would be able to work. So they're looking at that as one of the options. And we've been talking with them at great lengths regarding this, and FCC, they recently had a conference that we participated in. FCC came out and spoke with them regarding the cell phones, and FCC was very clear that 911 calls will not be disrupted through this process. And so I wanted to assure the board that in any pilots that they have in the future, in their bids that they're going forward with, they're making it very clear that the 911 calls will not be disrupted. A lot of their prisons are near local communities, as well as there could, the parking lots, people could call 911 from any of that area. The way the managed access is, we can never truly contain how the airwaves go out. So 911 calls will not be impeded. So I just wanted to let everybody know. In addition, they're looking at other solutions. They're looking for airport-style security, canine detection. They actually have dogs that can detect a cell phone. They're looking at clear technology, which is anything that comes into the prison has to have a clear case so they can look inside of it. And they're also looking for new legislative efforts, and Senator Padilla has been carrying a new legislation regarding the cell phones in the prisons. So I just wanted to bring that up in case any vendors or contractors contact anyone, that 911 calls will not be impeded in any of this process.
Ms. Wong, Sam Spiegel on behalf of Cal Chiefs. I've got quite a bit of experience with this, having actually 2 prisons whose property butts up to the police facility, both Folsom Prison and California State Prison, at Sacramento. So between the two, it's about 6,500 of California's finest citizens behind bars. And this is a real problem. But I want to go out a little bit on a limb here and say something in support, and I really mean this, in support of CDCR. They're trying to treat the symptom and not address the problem because, for whatever reason, most of which everybody will understand, there seems to be a reluctance in the legislature to pass laws that are at least have a severe enough penalty to make this a deterrent. And right now, misdemeanor possession of a cell phone in a prison amounts to about nothing more than a disturbing the peace. And so for CDCR to be trying to look at technologies that we have to make adjustments to or try and mitigate, it should be our efforts from our collective groups to see what we can do to help support CDCR and the legislature in going about this legislatively and punitively for the violators. There isn't a problem with the 911 system, and there isn't a problem with the use of cell phones. There's a problem with prisoners being in possession of cell phones. And most of the 911 calls is just a test. The only reason they're dialing 911 is to see if they've got cellular connectivity while in the prison before they strategize when they'll make their appropriate call. And that's the reason they're doing it, but it results in a 911 hang-up. And the long and lat of that call is not that accurate when you're dealing with a prison facility. Of course, depending on the carrier as to what you get, it could be anywhere. And it is a genuine concern, certainly, that if somebody's in a visitor parking lot or something like that and needs assistance of any sort, they should be able to dial 911. So I would offer to the committee that reach out through your organizations to the legislators that are considering sponsoring legislation, and certainly encourage them that this needs to be a felony, not a misdemeanor. It needs to be punitive enough so that we can get conformance with the right behavior that should be occurring behind the prison walls, and to stop placing an additional burden on the entire 911 system. Thank you.
Okay, thank you. Any other comments? Okay, now for the data and technology collaboration for next generation 911.
I asked that this be put on the agenda because, as I have said on a couple other committees, the thought occurred to me as we're moving through Next Gen 911 and the public presentations that the vendors that we're having do presentations and talk with us about the future of the next generation of 911 are solely focused. I can't say solely anymore after the doctor's presentation, but prior to that, we're solely focused on answering the 911 call and all of the advancements that are being made in the accessibility to a 911 center. What's completely, it appears to be completely void, is the collaboration with all of the other data and technology groups that are working on those other things that occur in our comm centers. You know, as Lisa talked about, I mean, the medical side and the EMS side of this is at most 20% of most of the PSAP calls. And so what's happening, what I'm fearful of, is that we're going to get into a silo effect again of the design of what next gen 911 is going to be, and the rest of our industry that works on the computer-aided dispatch from the standpoint of your call distribution, even the mapping issues, that those are not congruent with each other, that the architecture is open enough so that the things are being done together. So what I wanted to put on the record a request that the office work to bring the collaboration in. There are two, I know there's two task forces at least, and I'm sure there is more with NENA that could bring. I'm sorry, I misspoke, with APCO, that could bring more of the field to the table. Now, this sounds late. I mean, we're talking about April already, but certainly in the specification and the architecture of this, we have got to leave it open so that the integration of our phone answering software goes well beyond in next gen what it's currently being talked about. We're not talking about how does it assign, make a recommended unit allocation with the software for your computer-aided dispatch. Oh, and then how about your data going to your records management system? Where are all those people in next gen? Where are we at with AVL and its integration into next gen 911? Maybe that collaboration's occurred, but I haven't heard any of it, and there was no evidence of that as a result of those people doing presentations at those meetings. Chief Lisa Solomon from the Paso Robles Police Department chairs the statewide data and technology committees on behalf of state sheriffs and police chiefs. She co-chairs that with Sheriff Christensen. Thank you. And those meetings are actually held monthly at CHP and have been going on for a couple years now. And although equally absent from them, and I talked with Chief Solomon just this last week, Next Gen 911's off their radar screen. So we need to bring that together, and certainly anybody else that you think of as representative groups, so that we don't end up with a roadmap of silo in technology. That's my concern. And I've given that information to Karen, and I know that she'll be reaching out to Lisa to try and get something together in some way, so that at the very least that there's some collaboration on behalf of our contractor at the very least.
Well, at the risk of waxing too technical, okay. Part of the whole reason for the Next Gen 911 is to bring the 911 up to the IP standards, to the data standards. Once we've reached that point, then we should hit the radar screen of all of these groups. As it is right now, we're an analog sitting out there on the side, and we can't touch any of those guys, and they can't touch any of us. Once we put an IP platform in, then the window's open and the door's wide, and we can start bringing all of that stuff in. But the necessary first step is to go to that IP platform. Now, what you're saying, bringing these other groups in and getting their data in the formulation of our IP platform is not a bad idea. IP is IP is IP, but bringing them in so that we know how wide our bandwidth needs to be, as we're doing those things, is an excellent idea. One of the things I thought about when the doctor was giving his presentation is, yeah, why would we be looking at an EEG or an ECG or a video of the patient at the comm center? If we have enough bandwidth, we ought to be passing that information directly to UCSD ER and having a doc look at it and give that information to the people at the scene.
But I take it just even a step further, Chris, when I suggest that when we're looking at this right now, determine the bandwidth, and at the same time, what are the available infrastructures? And I know my friends at DOJ do not like my commentary on this, but the state has a huge pipeline with Department of Justice that exists. And so instead of us coming up with a next-gen strategic plan that talks about bazillions of dollars to build out the infrastructure for the future, what infrastructures exist that we could expand that are already built for IP, have already just gone through the very transition that we're talking about, and what collaborations can we look at to make those things happen? And I say it would be a noble yet appropriate endeavor for this group to try and put forward that attempt to bring the collaboration together and to look at that.
Chris, I have a question for you. What about the statewide broadband project? I mean, is that going to be something that we could tap into? Is that going to be a platform that we could potentially look at? I mean, that's going to be large enough of a pipe to get the types of information and infrastructure. The bigger concern I have is that we have all these different variant vendors who don't want to give up their code You know what I mean? So that you can't get their, you can't play with them unless you pay them money. That's one of my concerns. If we're building something and we say this is the specification, if you want to play with 911 in the state, then you all have to open your door and play on this level. And can we leverage somehow the broadband infrastructure to provide that support for 911?
Yeah, and there's the state microwave, digital microwave system, and there's all kinds of availability out there for bandwidth, and identifying which bandwidths will benefit the program and how we get access to those is certainly one of the issues. One of the other issues will be security with the IT entities in all of the individual agencies. Because right now, anybody who is not part of my sheriff's department IT infrastructure is not getting into my sheriff's department IT infrastructure, period. We're going to have to raise the level of security on the 911 system to the point where the individual agency IT entities are accepting of that security level and will allow the 911 system to interact with the records management system, with the CAD system, with the other data systems within each of these individual agencies. And that is going to be a monumental hurdle to get over, as we've evidenced with CLETS and DOJ, and getting DOJ to accept wireless access from a patrol car into the CLETS system so that we can make data dips into the information that's already residing in DOJ. You know, so being able to hurdle that IT security issue is going to be another big one that we're going to have to address when we want to take in the whole picture.
I agree, but in defense of or sticking up for DOJ, I think the last 2 to 3 years has seen a quantum leap forward in openness and receptiveness to these types of things, particularly with a strategic plan that moves the efforts forward. The integration of those things are occurring, and this is why this Technology and Data Sharing Committee was formed, because the sharing of, from the law enforcement side of data has started occurring as a result of COPLINK. And so the COPLINK agreements that have been forged through JPAs up and down the state is a model that can be looked at for those types of things. And they have broken down a tremendous amount of the barriers that existed before with the, and I don't want to be pejorative, but the fiefdoms of IT groups that have come along and said, well, my security levels are, these are my security levels and yours doesn't match. And through the desire and the absolute need to do our jobs, we've had to share data. And not sharing it now brings about questions of, you know, why couldn't you identify that registered sex offender was in your area when this data existed 2 counties over, and you should expect that person drives through your area, and it was siloed over here in this records management system, and you didn't have access to it. It's been forced in that way, and so I think there's a lot of progress made with that. I think that this joint committee, this was 2 committees at one time that got brought under one person. It is being participated in from a law side, and I think that as the discussions progress from your office, Karen, I think that it'd be a great opportunity to kind of get it opened up into the realm for law enforcement to see a broader perspective of those people that need to be at the table, including the representation of those people that are here.
And Karen, Lisa Huffman, I have one more comment to make about data sharing. HIPAA is more restrictive than CLETS. I mean, how are we going to, I don't even understand how we're going to begin to get over those obstacles. I mean, literally, HIPAA is the most restrictive thing that I've ever seen. So, I mean, I'm not sure exactly how we're going to design this system that has all this warehouse of information that we're going to be able to translate to. We're going to all have to be signing forms all day. So HIPAA would have to either be revised, upgraded, or some level to actually be able to be used in the format that I see the
Leslie,
development?
I actually think that the CopLink model is going to be an application technology that you'll see that what looks like this undaunting task with HIPAA requirements right now is going to be so easy. And the example that I would use, some of the most coveted information files in law enforcement is intelligence, gang, narcotics, all of those things. Well, all of those things are appropriately siloed in this connectivity of data sharing. And depending on the agreements with whom and at what level that data will transfer between agencies and where it goes within their systems is the very essence of what this data sharing project going statewide encompassed, and they're doing it. So the fact that it's HIPAA and not a gang intelligence really doesn't matter, because the criteria and the protocols of who gets to access it and what level of information can be set in the software for data sharing. And I'm not pumping CopLink. I'm just saying this has been paid for. It's licensed. All of the licenses were paid for the entire state of California. So there's still money that has to be, there is some money that has to be put up by local agencies, and and servers, and a JPA most often is the preferred overarching structure for geographical areas. But these nodes that have been established in groups together have found ways to get past all of that with some of the most protective agencies of their data in the state, and it's working. And it's networking not only with California, but you're finding major cities tying into this now and doing this, such as Boston and Philadelphia, in sharing that type of information that's taking siloed data and integrating it into things. And I'd offer that certainly from our standpoint as it relates to better delivery of 911 services, certainly from the EMS side, to be able to, on the fly, being able to share some of that information, I think is going to be a tremendous benefit to the community.
Yeah, and I love CopLink, don't get me wrong. I'm just concerned because there is a lot of information out there that dispatchers don't have access to. We don't automatically get access to criminal history information. We don't have a lot, some of those silos really are restrictive to people with the right to know, need to know, and not all agencies feel that their dispatch center have a right to know, need to know. And so that's the only thing I'm concerned about with HIPAA. Is it going to be the expectation that the dispatcher has to translate all this information, translate all this data, or can we push it through to somebody else who's going to actually need that information?
And that was, I think you got that. That was my point to the good doctor, that let's not just stop at the design of this and say, we've got all of this new technology, dump it into the comm center. That is the worst possible solution to next gen that we could have. Is, take the data, instead of it being a data dump, let's be discriminate about what is the data, who is best served by the data, where can it be best put to use, and not create additional training requirements and greater costs, obviously, to the PSAPs to continue doing our business while accepting new technology.
Thank you. Brilliant.
I just want to add, we're doing a project, a regional CAD interoperability project on the fire side. It's going to extend hopefully into the law side, but we're sharing that data. It's not necessarily coming to the dispatchers, going right to the MDCs where they need it. And so that no matter what agency needs that information, they're going to see it the way they are used to looking at it on their MDC. So it's happening right here in San Diego. And those are the kind of things that we need to be looking at, is not necessarily having it stop at the dispatcher, that it just gets pushed out to where it needs to be. And we've overcome that with agreements as well.
Okay, any more discussion? Okay.
Thank you.
Thank you very much. I just think these discussions are really going to help us move toward, excuse me, where we need to be for next generation. So I really appreciate the interaction. Next, technology work group update. And I kind of wanted to explain a little bit. We have a technology work group, and some of you are actually a part of it, but we've never made it official part of the presentation to the board, so we put it under new business, and it will become part of our ongoing updates in the future.
And as you all know, that work group is to review new technologies that could impact the 911 system. And the members are Ryan Doolin, Wes Nita, Sharice Bartlett, who are all in our office, Dee Dee Teal, Michelle Bland from the Highway Patrol, Chris Henshaw, Lisa Hoffman, Leslie Wilson, Ella Satella, and Hanan Harb. And this group began again on January 25th, and they have conference calls every other Tuesday. Any questions? Thank you.
Well, I just want to say that that group also is going to be important, too, as we start these discussions and their reports for the long-range or the next generation 911 planning group.
Absolutely, and we need to start utilizing that group probably even more in the future because we do have a good representation on that work group.
And just for info, one of the things that we've been looking at through the technology work group is different types of devices. And just recently, within the last couple days, we tested a device called ZOM, something that some mother created because her kids kept losing their cell phones or something. But with this device, if you press down and hold the button down on it, it sets off an alarm. That's the way you're supposed to be able to find your cell phone, apparently. But if you keep holding it down, then it automatically calls 911. But it calls 911 with a recording that says something like, this is an emergency. If you don't hear from a live person within a few seconds, then send help to this location. So I tried it the other day, and I get answered, and the dispatcher just says hello. I'm like, is this 911? And they said, yes, it is. And so I explained to her what I was doing, and she said that she received the recording. So that's part of what the technology work group is doing, is looking at these different devices or ways of accessing the 911 system and documenting issue papers. And the ZOM was part of the issue paper on recorded messages coming into 911. So that was just another technology other than like M-finders and things that come into 911 with the recording.
So Reggie, are you looking forward to getting all those calls?
No, that sounds like a recipe for disaster. You know, especially if you press the button to try to find your cell phone and it's not at the same place. I don't know what the range is for the ZOM device, but if
I can show you. It's in my purse.
Yeah.
We can test it right here if you want.
Yeah, but you know, if the cell phone you're looking for is in your car outside or a few blocks away or something, and you press that device, and now the location you have at the dispatch center is someplace other than where that person is.
Correct, and if your phone, because it's basically like a speakerphone for your cell phone. So if you push it and you're not anywhere near your device, it's still going to call 911, but you won't have that two-way communication.
And you also don't have any inkling of what type of emergency. So is it a fire emergency? Is it something that you need law enforcement for? Because you're just getting a recording. It's
correct, and it's just going to whatever center that the cell site hits. So.
Mm-hmm.
The other problem I love is for ACD centers, the call goes in, if they get picked up by the ACD loop, then the recording is in the ACD loop, and the dispatcher gets the call and they don't hear anybody on the line, they just disconnect because it doesn't, I don't know how many times the recording cycles or what the levels of the cycling is, but you know, if you just happen to make it right during the time where there's no voice, you don't hear anything, you try to call it back, well, they're not near their cell phone, so they can't answer their cell phone. Some agencies do send an officer out, some agencies don't. They make a call back or an attempt. So every agency is different. There are a lot of problems, and I think public awareness is going to be key for us to get the information out to the public.
Well, and these are the type of things that actually they should be getting some sort of approval process before they can access the network with that, but it seems like they're not, they're just bypassing or...
And that appears to be what is happening on some of these, and we are working with the CPUC on these issues, as well as consulting with the FCC, because I thought the regs were pretty clear about recorded calls and they're not quite as clear as I thought that they were. So we do have people looking in, and we are working closely with the CPUC and the FCC.
And Karen, I think one of the dilemmas is that it's a wireless call. Whether you activate it from a push button that you're holding on a key fob, or whether you're dialing the phone from your car or your home, it's a wireless call. The FCC has control over that, and I think something's going to have to happen to help us better provide 911 service to the community without overwhelming with these, for lack of a better word, abandoned calls.
Mm-hmm. Mm-hmm. Agreed. And I will try, because the FCC did commit to coming out and talking with all of you, so I will try to have them come to our next meeting if it will work with their calendars. If not, I may reach out to all of you if they have different dates that they can be here and see if we can move the board meeting. They have a really good perspective, and they have been working on this. Are there any more questions or comments regarding the technology work group? Okay, and then the last item on new business was a recap of the NG 911 public meetings, and we pretty much already discussed those. We will have information out by mid-April, a recap of the meeting. What we're doing is looking at, we've taped all the meetings, but since at least 3 of the presentations are the same at every meeting, we're looking at combining all the meetings and just having just one tape with one presentation each, so everybody doesn't have to weed through a bunch of information to get to what they want to hear. So we're putting that together as well. Philip, our webcaster over there, he's going to be putting that together for us. So that will probably be done by mid-April. So we will have more information on this. The final date to file the questions was March 18th, and so we're compiling those questions. And just so you know, with working with FCC, they've gone over the questions that we were looking for answers to from everyone, and they are interested in our responses that we've gotten as well. So did anybody have any more questions about the public meetings? Any discussion? Okay, then let's go back to our committee conversation that we were having earlier that we tabled to this time.
Okay, I think what I'm hearing is that we don't want to call it the Next Gen Committee, so let's just roll up the GIS and the hosted committees into the Long Range Planning Committee.
Okay.
So I'll make that motion.
Is there a second?
I'll second it, Spiegel.
Okay, all in favor?
Aye. Aye.
Opposed? Motion carried. Thank you. And now for announcements. I just have 2 announcements to make. We did file with the, I got my notes here. They just gave me an acronym. DOJ NPRM Accessibility of Next Gen 911. I believe the board members were emailed a copy of our filing, and they're in your packets as well. They're also up on our website. And then we also filed with the FCC for the framework for next generation 911 deployment. I believe all the board members were also CC'd a copy of that, and you have a hard copy in your packet, also again on our website. Did anyone have any additional announcements today?
Yes, I have 2, actually. First, our CalNENA Quarterly will be in Sonoma April 28th. And information is on the website about that if anybody wishes to attend. Also, I would recommend to the board members that they look at AB 770, AB 770, Assemblymember Torres. That bill proposes adding 2 members to this board, one from Post and one from the California Fire Marshal's Office, and charges the State 911 Office with responsibility for establishing standards for recruitment and training of dispatchers. The difference between this bill and last year's bill is that all of the funding issues were taken out of it. So there's nothing in there about how they're going to fund this, or if there's going to be any funding for it, or where that funding is going to come from. But the portions are still in there about the state 911 office being responsible for standards for training and recruitment, and adding the 2 members to this board. So I suggest that the members read that legislation and take it back to their constituent groups and contact their legislators and support, oppose, or modify the bill as appropriate.
Lisa Hoffman, just want to remind everybody, I know you're all aware, second full week of April is always National Public Safety Telecommunicators Week, so make sure you honor your dispatchers.
I just had a question for Chris. Has Cal NENA taken a position on that yet?
Cal NENA is working with Assemblymember Torres's office to modify the language of the bill.
Okay, any more announcements?
Mrs. Wong, and I guess maybe bringing, now that we've looked at the long range, the GIS, and the third committee, and joining that is, how would you describe the next gen committee then? Is essentially the data and technology collaboration going to take that function? Who would we, the board, look for to bring that, besides the office, bring that together? And certainly from Chief Spiegel's perspective, okay, how do we have a variety of the disciplines functioning in that, or if it isn't the data and technology collaborations?
It was
wondering where that's headed. So.
Yeah, it was my understanding through the motion that it would be the Long Range Planning Committee, unless I totally missed your question.
Chris, could you go back to, I hate to ask you to do that, the motion and maybe the action. I thought I recalled that being long range, the GIS and the consolidation hosted solutions. But I'm wondering, okay, now does next gen fit in that, or is that next gen really something that is this data and technology? So.
Well, what the motion did was roll those 3 committees into the one.
Right.
Okay, so we're consolidating that.
That was my understanding.
Is it going to address next-gen issues? Sure. Long-range planning is still going to involve next-gen issues. So, yeah, that's going to be part of the discussion. But as Chief Spiegel said, it needs to be broadened to all of the members of the board. So anything that we do in the long-range committee that has anything to do with next-gen is going to come to this whole board. It has to. We can't do anything on our own anyway.
And that was my perspective from what I recall our direction. I'm just thinking that, okay, this next gen, because of the scope is the bigger thing out there. It is bigger in scope than, let's call it, the long range committee. And so I guess, you know, how do you bring that one together? And it just sounded like the data and technology and the list that I think Carolyn had read off of names looked like it had a great cross-section of people that wasn't the long range. Some of the same people, but it wasn't long range.
Right, that committee includes others than the board members, yes.
And it sounds like that is, I guess where I'm trying to get that, it sounds like that is the committee for the next gen. And certainly would there be some overlap, but I'm thinking, okay, maybe it sounds like that's it.
Yeah, no, there'll be overlap. The technology work group is specifically formed for specifically looking at new technologies. That can be next-gen stuff. It could be somebody's coming out with a new cell phone that does something weird with 911. I mean, any new technology that touches the 911 system in any way whatsoever, that work group's supposed to look at it, evaluate it, and evaluate the effects on the 911 system, the PSAPs, so forth. That's why it has that broad range of membership to do that. Do we want that kind of broad range of membership on a next-gen 911 committee? Sure. Yeah,
And
maybe we need to
where does that
create
next gen
something
go?
like that.
Okay.
But probably more important than doing that is to go back to Sam's suggestion that we talk about meeting monthly. We need to address that. And next gen is coming. We've got the roadmaps in process. If we agree that we all need to have our input into that project, and certainly what Sam brought up about the Data and Technologies Committee in the Police Chiefs and Sheriffs Association, that's information I didn't know about. And the agreements that he was talking about between the IT silos and all of that with the CopLink and all of that, I'm not sure that L.R. Kimball knows that those agreements are in place already in the state of California and that we could leverage those for the next gen 911 effort. So, I think there's plenty of reason for modifying our board meetings and start to do them monthly for the next 6, 8, 9 months, until we get some of this NG 911 stuff,
and
under
after
the bridge.
thinking about some of the discussion it was, again, if the board meets, the logistics of that makes it certainly a lot of work for the office at all the board. But certainly in what I heard Chief Spiegel say and what I'm supporting is there needs to be representation from all the disciplines on this next-gen function. But I think, though, that if you try to bring the board together every month, it can be done. But certainly I think it's much more cumbersome than I'll call it a next-gen committee with all the disciplines involved.
And I would not be adverse to having those meetings all in Sacramento for the ease of the office, so they're not having to monthly go somewhere else in the state to have these meetings or to handle all of the issues with moving personnel around with these state travel budgets and so forth the way they are. It's much easier for us to arrange our own travel up there and put in a reimbursement request than for them to try and do state travel.
There also is, I just found them yesterday, new guidelines for Bagley-Keene where they address teleconferencing. And I don't believe it is as rigid as it has been in the past, but I do need to go back and look and see if it would apply for us, that maybe we can have these monthly meetings and have teleconferencing and still meet all the Bagley-Keene requirements. I just got them out yesterday, so I need to completely go over them, have staff assigned, and see what we can do.
Thank you, because I was just going to ask that question. I had heard that there was some loosening of the reins on that, and, although San Francisco to Sacramento, it's not that big of a deal for me, it's significant for San Diego people to come up, and even for me, depending on traffic, I may rather just call in.
Well, and if we're going to do that, I'd like to suggest that the office upgrade their equipment and do video conferencing instead of teleconferencing.
What we could probably do without upgrading our equipment is to find a location with updated equipment and have our meetings there in Sacramento.
And I do know that Post has offered in the past, and I think you guys have got capability at your shop now, too.
Yes.
Yeah, CHP's right next door.
I hate to venture this, but Calima has that availability at their office, too. But okay, just thought I'd get it in there.
Might take 4 years.
Excuse me. I just want to point out that we're in the process of looking at getting a contract on teleconferencing, given the state's fiscal situation. Oh, Christy Quinlan for the record. And it'll be available to all the state departments. It'll be available via the OTEC contract, supposedly off of maybe CalNet 3. But to your point, Chris, we would be able to set it up for video conferencing, and it would include new equipment. Yay. So I just want to throw that out there. Karen was sounding like she wasn't aware of it, and she might not have been. So it'll save you, the 2-hour drive.
I'd prefer we not video conference, but that's okay. I can
it's
go,
teleconferencing.
I can't wear my pajamas. So, no, just kidding.
It's just a matter of where you position the camera.
Yes, exactly.
So you could be in your PJs. Well, however you angle it. So just FYI, we are trying to set that up to avoid all of the travel. Okay?
I appreciate that. I was not aware of it. Thank you, Christy.
I don't want to belabor the long-range planning issue, but if these other groups have been rolled up into long-range planning, I'm looking at handout 4, is long-range planning composed of 3 people, or are all the people in those other groups part of long-range planning group now? What's the membership? Or is it everyone?
Yeah, the long-range planning committee is 3 people. It's the 3 members. And we can pull on other members and other people to assist us in whatever planning, we see or need. So I believe that was the original intent. Now, there's certainly nothing to say that somebody else can't volunteer to be on the long-range planning committee and add to it.
I'd like to volunteer.
I thought you were on it, Reggie.
Well, I'm not listed, so I wasn't sure.
Well, actually, Reggie, I believe you are on it. I don't know what happened to that, so.
Oh, okay.
Yeah.
Well, I'd like to reaffirm my commitment here.
Yeah, just for clarification, right now, it's Chief Bryant, myself, and Sheriff Bonner, and Reggie now.
Yeah, and
So,
we will go back and check the membership, but yes, Reggie, you were part of that group.
Okay.
We wouldn't have the strategic plan if you weren't part of that group as well. We all got together, so. Okay. Without any further comments or announcements, are there any public comments today? Okay.
Motion to adjourn.
Second?
Second.
All in favor?
Aye.
Opposed?
Thank you all.
Opposed?
Meeting's adjourned.